Hello, everyone. My name is Diana Amarillo. I'm from Uruguay, and our group was integrated by otorhinolaryngology, surgeons, medical oncologists, and therapeutic oncologists. Our job was survival impact of treatment delays in head and neck cancer experienced from a university hospital in Uruguay. Head and neck squamous cell carcinoma accounts for more than 650,000 cases and 330,000 deaths annually. It's the sixth most common cancer in both Europe and South America. The most important prognostic factor in these patients is stage, according to the American Joint Committee on Cancer. Timelines of access to care has a proven impact on head and neck cancer outcomes and is identified as a preventable source of mortality. Quality of clinical care for head and neck cancer is scarce in Latin America, and we do not find publications about time to initiation to treatments, TTI, in our continent. This study aims to analyze the impact of TTE on survival in Uruguay. We received an anonymized cohort from a hospital-based prospectively collected hospital database. We analyzed patients with squamous cell carcinoma of head and neck cancer, stage 1 to 4, performance status of code 0 to 2, who received treatment with curative intent between 2005 to 2015 at the Hospital of the Clínicas Montevideo, Uruguay. The Institutional Review Board approved the research. We defined TTE as the number of days between histopathological diagnosis and the first curative treatment. Recursive partitioning analysis, part of our software, was used to examine a possible timed a point of cutoff that affects survival between the histopathological diagnosis and the first curative treatment with impacting overall survival. We include 480 patients with head and neck cancer. The mean of age was 62. We can see that 80% of the patients was male, 80% of the patients was smokers, almost 70% of the patients drink alcohol and consume mate, an Uruguayan drink. And the majority of the patients have a locoregionally advanced disease. 377 patients received treatment with curative intent. Patients with performance status 3 or 4 time to initiation to treatment over 1 year were excluded. The first treatment was radiation therapy with chemotherapy or not in 42% of the patients, and surgery in 57.8% of the patients. The median time to initiation to treatment for each treatment was 32 days, radiation therapy 61 days, and surgery 22.2 days. The median overall survival was 36 months for patients with a time to initiation to treatment of 40 days or less, while the group of time to initiation to treatments for 40 days or superior was 23 months. This difference was statistically different, significantly different. The 5 years OS rate were 41.5% and 21% respectively. The difference was observed in patients with radiation therapy, 35.7 versus 21.1, compared with patients with surgery, 49.9 months versus 34.2 months. This difference was statistically significant. The median survival in larynx cancer was 70.5 months for patients less than 14 days versus 27 months for the group over 45.5 days. For the anatomical side, the overall survival was 29 versus 20 months. For localized disease, the median overall survival was 118 months for patients within 40 days or less versus 55 months for the group over 40 days. In advanced disease, the overall survival was 27.6 and 21.1 months. Then we made a multivariate analysis to determine if these factors have an independent impact in overall survival. And as we could see in this table, the site, larynx versus non-larynx, the stage, obviously, and the time to initiation to treatment was independent factors that influence in the overall survival. The hazard ratio for time to initial treatment was 1.29, and the difference was statistically significantly different. As conclusions, well, this is the first study to analyze this factor and impacts on the overall survival of patients with head and neck cancer in Uruguay. Our study describes that a time to initial treatment of more than 40.5 days negatively affects the overall survival of patients with head and neck cancer, regardless of the disease stage or the anatomical locations. Further studies must focus on the causes of such delay to improve our therapeutic outcomes. Well, thank you so much to everyone.
Thanks, IARC and organizers, for giving us this opportunity to share some of our data with you. So I'm Shahid Parvez, and Namra Anwar, a scientist, PhD, did most of this bench work with me. So I will be talking, will keep myself very focused, because in 10 minutes, can only share a little bit, and it may raise many questions in your mind, which maybe at some later stage I may be able to address. So prevalence of high-risk human papillomavirus 16 and 18 in oral cancer of a high-risk population of Pakistan. So I'm from Karachi, the largest city, the port city, industrial city of Pakistan, with a population of over 20 million. And this is Karachi, sprawling Karachi. And this is our campus right in the heart of Karachi on about 80 acres. And this is our Faculty of Health Sciences, and Department of Pathology is the one which is also College of American Pathologists accredited. So this is map of Pakistan, and here it's Karachi. And as I said, it's the most populous city of Pakistan. In fact, one of the most populous cities in the world, with a population of well over 20 million. Incidentally, I also chair Karachi Cancer Registry, and this is the last data which we published from Karachi Cancer Registry, and some salient features of that. If you can see that from 2000 to 2019, and the trend is continuing, the oral cavity cancer is the most common cancer in males of Karachi. And if we talk about females of Karachi, obviously the breast cancer is the most common cancer, very common cancer. However, oral cavity cancer is again the second most common cancer after breast cancer. And this is Globacam, and you can see that if both genders are combined, oral cavity cancer is the second most common cancer in Pakistan after breast cancer, and obviously the most common in the males. And This is the most common cancer we diagnose. I am a histopathologist, so the most common cancer I diagnose in my day-to-day practice in a hospital setting is the oral cancer. And many at times they present at a very advanced stage. You can see that this is the starting from here and going through and is ulcerating outside. This is, the involving the tongue, and the surgery which happens, it's like a nightmare. The whole tongue is chopped off, whole jaw is chopped off. So a very bad life quality after uh, having the radical surgery for oral cancer. And this is a woman, and you see the neck is bulging. Why? Because of the bulky metastasis, from the oral cavity to the cervical lymph node. And what are the major culprits in Pakistan? Actually, these are peculiar to this region, the subcontinent Indo-Pakistan. The chewing habits. In the rest of the world, or most of the world, the smoking and alcohol are the common reasons for oral cancer. However, in Pakistan and in Karachi, about 80 to 85% uh, patients who present with oral cancer, they are actually addicted to chewing, tobacco, betel leaf, betel nut. I will come to that. There are several uh, dubious products, which are available in the market, in the ready-made form. So chewing is the most common cause of oral cancer in Pakistan. So much so that Namra, when she was doing her PhD, she found it challenging to recruit patients of oral cancers who were not chewers or smokers. So, coming to actual study. So, in this study, 186 samples from 186 patients were tested for high risk human papilloma virus type 16 and 18 by PCR, and a subset of these, that is 50 cases, were also stained with P16, which is a surrogate marker for high risk HPV, and we pathologists, histopathologists commonly use it in particular for cervical cancer. So the results are quite uh, revealing that high risk HPV presence was seen in only 7 cases by PCR out of 186, that is only 3.8%. Out of these 7 cases, which are positive out of 186, 5 were positive for high risk 16, while 2 were positive for both 16 and 18. Now, the overall expression of P16 immunohistochemistry in 50 samples was 38%. So 19 out of 50 were actually positive for P16. Among these 19 positive samples, 26% were positive for both high-risk HPV DNA by PCR and immunohistochemistry, while 73% who were PCR negative were also positive for P16. Hence, there was no significant correlation between the PCR testing and the P16. So these are some of the gels, and this is the immunohistochemistry. And we pathologists actually are tuned because of the cervical cancer, because we always do P16 immunohistochemistry on cervical cancer because of it's almost about 100% association with high risk HPV, that the positivity should be block positivity. It means both cytoplasmic and the nuclear positivity. So in conclusion, it is concluded that prevalence of high risk HPV in oral squamous cell carcinoma is very low in our setting. that is the high-risk population, which is largely addicted to chewing. So in contrast to well-established significant association of high-risk HPV with oropharyngeal squamous cell carcinoma, which arises from the base of the tongue, the palatine tonsils, soft palate, adenoids, where it's established and it's the standard of care. In oral squamous cell carcinoma, the prevalence of HPV is very low. So why it is so? So a plausible explanation in chewers is that with time, chewing leads to hyperkeratosis or oral submucosal fibrosis, posing a physical barrier to the penetration of human papillomavirus. Mind you, that cervical epithelium is non-keratinizing, so HPV may easily penetrate. Again, oropharyngeal cancer, oropharyngeal normal epithelium is largely non-keratinizing, and hence HPV may easily penetrate. The oral mucosa is variably keratinizing, depends, the function of various parts of the oral cavity. However, we believe that because of the chewing and the physical irritation with time, it leads to a thick keratin layer, which appears as a white patch, and obviously this oral submucosal fibrosis, which is peculiar to this part of the world, probably may make physical penetration of the high-risk HPV difficult. So this is my final slide. So oral submucosal fibrosis, which is a precancerous condition for oral cancer, is largely restricted to this Indian subcontinent and is an established condition to have a direct correlation with areca nut chewing, which is also quite common in Pakistan. More recently, however, we have seen a transformation, from the traditional chewing, ingredients to some which comes in the sachet form. They are highly addictive and highly rampant, even in the adolescents and young population. So the powder which is kept in mouth for hours, leads to prolonged exposure with the oral mucosa and the carcinogenic contents which are present in that, leading to mutations and eventually the oral cancer. So finally, I acknowledge the Aga Khan University for its grant to support this study, and thank you for your kind attention.